Today is December 15th, 2022. My name is Karen Neurohr, and I'm at the Oklahoma State Department of Health office in Oklahoma City. I'm with the Oral History Research Program at the Oklahoma State University Library, and today I'm talking with Oklahoma Commissioner of Health Keith Reed about his experience during the COVID-19 pandemic in Oklahoma. We will be focusing most of our time discussing his role as a public health administrator, but I have some more general questions about life during this time. Upon the agreement of Commissioner Reed, this interview will be archived at the OSU Library for future generations to see. Thank you for having me here today, Commissioner Reed. Could you tell me a little bit about yourself, please?
Sure. Born and raised in Oklahoma, specifically from eastern Oklahoma, a very small town called Monroe. Went to high school in Poteau in LeFlore County. I'm married, have been married for 35 years. I've got two grown boys. I've been in public health for 20 years, a little over 20 years now. Started working in the Pittsburgh County area as a nurse working with the bioterrorism preparedness in the state. That occurred shortly after 9/11 and when there was a renewed focus on bioterrorism preparedness in the country. So again, been with the agency about 20 years. I've kind of moved up through the organization. Spent most of my time working local public health with health departments, into being a regional director for several years. Came up to the state office in 2018 as a deputy commissioner for community health services. And then I find myself as commissioner of health, which occurred about late October of 2021. I'm also a member of the Oklahoma Air National Guard. So I'm an Air Force officer, currently hold the rank of colonel. I've been in about 28 years in the military, so I've got that experience as well.
Did you go into the Guard right out of high school?
So I went into Army Reserve right out of high school and spent about 4 years in the Army Reserve enlisted. And then I ended up going to nursing school a little later in life. I was full adult, not grown kids, but kids, family, all that, and then decided to go back to college. Got my nursing degree in 1997 and decided to return to the military. I went to the Air Force side as a commissioned officer as a nurse, and that's where I joined the Air National Guard. So since 97, I've been in the Air National Guard.
Okay. So take me back to when you first started hearing about the coronavirus. What are your memories of first realizing this pandemic was going to significantly affect day-to-day life?
Well, before we actually recognized that we were going to have that broad impact, when we started to really recognize, okay, this is really going to be dangerous and going to be a problem. We were kind of watching what was going on in China and, hearing little bits and pieces about there's an outbreak and it's, spreading, and that periodically happens over time. And we kind of monitor that in public health, and we hear about these outbreaks, and, typically they don't really go anywhere. They don't expand the way we saw this one, obviously, and thank goodness that's the case. But it was really getting into, if I recall, February of 2020 when it really started getting the sense that, okay, this is something that's probably not going to be contained, and we need to really start monitoring this closely and preparing for this.
With Oklahoma being in the middle of the country, did that in a way allow a little more time, since it was hitting the coastal areas first, to come up with a good response?
Well, let me first say that we had plans in place. We had specific pandemic flu plans in place. We have preparedness plans in place. As an agency, we have our emergency preparedness and response service in place. And we've done tabletops, and we've done all types of approaches to ensuring that or at least where we felt that we would be ready for something like this. But we'd never really been tested to the level of what actually occurred. Much of that was discussion in theory tabletop, walking through scenarios, and all those, had time limited. It was a time limited experience. We're going to do this over a day. We're going to sit around the table, and you talk in theory about what you're going to do, and in theory that resolves the issues. Much different than the real thing, but it's what you have to work for in preparation. So we had those plans in place. And we also knew through experience that when we saw outbreaks of different types of things, that it's where, the international travel is the risk that brings it to the country. And we don't necessarily see a lot of international travel coming straight into Oklahoma. So yes, that does tend to give us a little bit more time, a little bit of a buffer, but certainly not much in this particular situation, the way it spread so fast.
Okay. And remind me again, what was your position with the state health department around, February, March 2020?
Sure. So I was a deputy commissioner for community health services. So basically, I was over our 68 county health departments that are under the purview of the State Department of Health. And then we have some other programs within the agency that, maternal and child health, immunizations, screening special services. There's kind of a plethora of different programs that are executed through our county health departments. Those are under my purview at that time.
Okay. And who were some of the key people involved in the early months of the response?
So early on, I would look at that in two different ways. One, I would look at it as an agency who was really, integral in the involvement early on, and then who in the way of, our partners and others. So early on, the triggers for an outbreak like this would be our acute disease division, because they're kind of charged with trying to stop the spread of communicable disease. Our laboratory staff, because that's where we test and understand, the spread of the disease. And then in this case, our emergency preparedness and response service, which is, one that kind of heads up our planning and preparation, and then really initiates our work under the incident command system, which is the way we would organize ourselves for a response like this. And then you get into all your frontline workers. So for us, county health department staff, we have nurses that are communicable disease nurses that are out there. Our epidemiologists from the state office working with them, our regional directors trying to mobilize local partnerships to really, evaluate what we're doing and get information out. Then our comms team is another one that's integral in that. And then obviously leadership within the agency. But very, very early on, we recognized in this one that this was one of those events that was going to exhaust our resources almost immediately and was going to require a broad sector approach to this. And so I know early on, we connected with the governor's cabinet and met with them. I recall a meeting we had at the Capitol where we met with cabinet secretaries when we first started, starting to recognize the potential scope of this. And we talked about some of the potential implications you might see. What would you see for agriculture, for commerce, for higher ed? We would kind of talk with the different sectors about what we might see. And I will admit there's a little bit of hope at that time that this was, just, preparation, and hopefully it wouldn't have that level of impact. But it wasn't too far into the future that we found ourselves kind of shutting down and really having that impact on all those sectors. And then it certainly held true moving beyond and getting further and further into the pandemic, that this was an event that was going to impact every single sector in the country. Every single thing that relates to supply chains. And there was just second, third order effects of this were just amazing. So all those partnerships mattered. And then probably where they kind of culminated on the partnership side from a leadership perspective is the governor's office set up the multi-agency coordination center. They call it the MAC. And this is where we had representatives from the cabinet, Our Office of Homeland Security, Oklahoma National Guard was very much involved with that. The health department, of course, was an integral part of that. And that's where we started really trying to coordinate the response among the various cabinets and the various sectors for the state. And that was a critical part moving forward.
When you said comms team, does that refer to communications?
Yes, that's
Okay.
our communications team.
Okay.
And at the time, we had a very limited communications team. It was a small group.
Mhm.
That has grown through the pandemic because we've learned the need for it. So that was an area where we actually had to end up relying on other agencies to help out early on. And then we ended up contracting with external comms organizations to help us fill the need, because communications was just critical during this.
Mhm. What were some of the top challenges in the beginning?
Well, logistics, I would say, was one of the major challenges. And this is when I reflect back, and being in the agency 20 years, I have been part of tabletop exercises and preparedness exercises and stuff for years. And I don't think we ever reached a point in the planning that we had a true appreciation for what the interruption in the supply chain would really mean, especially in an event where we're so dependent on China for our supply in the way of like PPE and other things. And this event started in China. So, manufacturing was impacted very early on. The other thing that we planned for early in previous years was a strategy around a strategic national stockpile. So the federal government had a plan. Strategic national stockpile was kind of always our fallback plan if we had supply issues, things around drugs, medications, PPE, things like that. We would reach back to the strategic national stockpile, and they would be able to supply us with those. But that was completely inadequate. There was not enough to meet the need, and there had been the challenge on PPE that if you store it in a warehouse, it sits and expires. Most people don't understand, okay, why would a mask expire? Well, the components of the mask tend to break down, especially N95 mask and its ability to filter. But there's also rubber components and things like that on them that also break down over time. So that PPE would expire. We actually had quite a bit of PPE in our warehouse that was left over from H1N1, and I believe it was 2009 in that area where we had the small outbreak, I would refer to it now, of H1N1 flu. But it was expired. It wasn't good for use with this. So we found ourselves in a position that logistically we didn't have the supplies to support hospitals, and we were looking at the predictive modeling for what we were going to experience and what hospitals were going to need. There was a point there where we looked at, okay, we got like a day's supply of this. So shuffling that around and really trying to coordinate getting personal protective equipment in to support our responders, that was a real challenge. And then again, in a scenario that differed a bit from the planning, the concern was that it wasn't just healthcare workers that needed that PPE and those masks and everything. It was the issues of all first responders, police, fire, that might get called out and get exposed. They needed it as well. We got into the issue of schools, trying to protect teachers and others. So supply issues. I remember testing. I'll give you the same example. Testing early on. We got the material or we got the kits that we could do a test, but it was the supplies that would cause a problem. And a test, the lab could have their equipment to do a test, but that does no good if you don't have swabs to collect a specimen. And so every time we would get, swabs in, then it would be, okay, we didn't have enough reagent to do it. Or we could have swabs and we could have reagents, but we didn't have transport media to do it. So the logistics of trying to support the early response was just an incredible challenge and a real impediment for us to be able to kind of get a smooth rollout. And because it wasn't just us, because it wasn't just, the United States. It was the entire globe was suffering from this. It was very difficult to get a quick recovery from that.
Mm-hmm. Yeah, that was occurring to me when you were talking about the logistics and the supplies. This wasn't just Oklahoma. This was everywhere.
It absolutely was everywhere. And even when we did reach a point that we were able to get a little bit of supply flow into the state, transportation became an issue. So, okay, maybe you have some supply that you can purchase, mm-hmm. but then you had to work with a whole different group to try to figure out how to get it transported here. So we started seeing a connection of multiple resources, trying to piece them together to create a logistics support system to bring this stuff in. It was quite a challenge.
Could you describe some of the partnerships that the health departments formed or strengthened to be able to deal with the pandemic?
Sure. Well, and there were many of them. And there were times that they were very strong, and then there were times they were very strained, just by the nature of the pandemic itself. So some examples I would give, our hospital partners, great partnership with them, but understandably, they would get really strained, stressed, frustrated when we weren't able to provide those supplies I talked about earlier, the mm-hmm. Personal protective equipment, weren't able to get that to them. Emergency management around the state, another key partner, but they also would get frustrated, and that relationship would be strong but strained at times because of the specific data that they wanted or needed for their area. And data was also hard to come by early on, especially good, effective, timely data. Schools. I remember many sessions getting on calls with state superintendents and, working with the state association, getting on calls, trying to answer questions, to provide some good guidance for the schools. Hospital association, long-term care, was another area hit incredibly hard early on. And that was the most painful thing to see early on, was the impact on our elderly and our long-term care settings. So working with those associations and facility owners and administrators, again, it's a partnership I would describe as strong because we're working together trying to resolve this, but because answers wouldn't come easily, it would also become strained at the same time. And I don't say that to say it wasn't a productive. They were all very productive types of relationship, but there was lots of challenges. First responders, in the way of police and fire, trying to, they wanted to know who in my area is positive. Early on, you got to realize we weren't dealing with the thousands and thousands and thousands of cases that we dealt with later in the pandemic. In the early days, it was more about hundreds across the state. And so in the community, the responders, they felt like, okay, we need to know who's got it. So then you have the challenges of HIPAA. Yes. And violating somebody's privacy, and what can you do under an emergency that you wouldn't do normally. That created some stress, but again, good conversation, good partnerships. The cabinets, I mentioned the different cabinet areas, working with the different sectors, all good partnerships there. I would say we probably had some kind of partnership with pretty much everybody in the state at some point, with varying levels of success about what we could achieve, because unfortunately there just weren't really good answers early mm-hmm. on. Media. I should always mention media, because that's another one that you can always use an example. Very important partnership. I know when we were doing vaccine rollout, I'd always refer to them, that they were part of our partners in getting that rolled out. The communication, the messaging that we need to get out, they really helped us with it. But then they would also come back, and hold us accountable for data and information, which is their job to do so. So again, there's aspects of it. This is great. Now we're working in concert, and then in another few days, maybe a little bit, at least a perception of we're at odds. We really weren't at odds. it was the challenge of the pandemic. I often told my staff, regional directors, I would call it the COVID conundrum. Whatever answer we have, 50% of the people that we're working with are going to be okay with it, and 50% are going to be unhappy with it. So it's like we really had difficulty finding solutions that would work for a majority. Because even if we got supplies in, then we had to make a decision about who do these supplies go to, because it was limited. It was always limited, especially in the early days.
Sounds like it was a really stressful time in a lot of ways.
Yes. Incredibly stressful. It really was, especially when we looked at the modeling and knew what the potential was. And, if you recall early on, it was about flatten the curve. We kept talking about flatten the curve. And our goal early was really not necessarily that we could stop the spread, but that we could suppress it enough to give our hospitals and our healthcare system enough opportunity to deal with it. Because that was a concern, that they would be overwhelmed with the wave that we saw coming, and then we would have people out on the streets being, taken care of in the streets, and we didn't want anything like that. And we knew we didn't have the supplies to support them either, so we had to buy time while the supply chains and things caught up for personal protective equipment, for ventilators, for some of those life-saving type of resources. So yeah, incredibly stressful. I know, really for everybody. Public health staff, had people in my office that were taking calls continually from staff. A lot of those calls were just, it wasn't that we necessarily had a great answer for them, but it was an opportunity to debrief and to really kind of just talk through everything that was happening, for somebody to be lending an ear for them. Calls all through the night, text throughout the night, just spur of the moment conference calls and pulling people together because of, the way issues would come up, and we'd have to try to find an immediate solution for some of these things. So there was a period of time there that it was certainly 7 days a week, and then there was the realistic expectation of being available 24 hours a day. And that went on for months. That really went on for months. So I always commend the staff that were really working the front lines during that time. And I looked at our regional directors and the ones that were in our county health departments. And, I recognized that for me, I had a bit of a filter between me and the public a lot. They were the filter. They're the ones out there that were having to field all those direct questions and dealing with, in some cases, panic, in many cases, frustration, in many cases, just questions. And they were constantly having to field those. So our frontline staff that were out in our local health departments trying to work through that, I just can't give them enough credit for what they dealt with. And it was stressful for everybody, but they really bore the brunt of it.
In what ways did your past experience working in the health departments and as a regional director enable you to deal with this at more an upper level administrative position?
I think even though I feel like our previous exercises and scenarios and planning maybe fell short for what we really experienced, it still gave us a certain amount of knowledge and preparation for where this could potentially go and what are the potential resources. So I don't want to discount all that work because it's very valuable. Were the plans adequate to meet the need? No, but we often talk about it. I know in a military life we talk about, a plan rarely survives the first bullets that are fired. It was something similar here. We knew those plans we had were going to have to be changed to adjust to the situation anyway. But the work of the planning, the efforts that go into that, the partnerships that are built during the planning and the preparedness, and in public health, much of what we do is about partnerships. It's about those relationships. always talk about the public health system, and we're the public health agency. Within statute, we have that authority and that responsibility and accountability, but still, we're one part of a public health system. Public health happens throughout this whole group. So all these partnerships and everything are just key to that. So the experience of working within partnerships and looking at population health and how that works and understanding how that works, I think is probably one of the best things that prepared us for this.
Is there something that you would change, that you would go back and change, knowing what you know now, or that with how things were happening?
To be really effective at that, I'd probably have to go back prior to the pandemic, and I would have a warehouse full of supplies. If I could do that, and I'll be honest with you, that's something that still haunts me now, because the instinct is, let's have a warehouse full of supplies in case this happens again. The reality is, we had a warehouse with a bunch of supplies that were of no use to us because they expired. So we still are working on ways in which we can kind of resolve that conundrum. How can we have a stockpile of supplies for the next pandemic that all have shelf dates on it? So, there's still challenges there. But if I could go back and I could ensure that we had the resources in place, that would have changed the entire tone of the response, because we started out behind and we remained behind for several months trying to catch up. And then we saw, even when the vaccination program rolled out, it was still an issue of limited resources and inadequate resources. So if I was able to really impact and influence the resource part of this in that supply chain, that's what I would love to be able to do. That's not really practical. I think it's hard to say what exactly we would do different. I wish we had better messaging. That I don't want to throw CDC under the bus, because they were in the same boat as we are. They're trying to figure it out as we go as well. It's a new virus. We don't know much about it. I know everybody wanted to point fingers and, why don't you know this? Why don't you know that? Because it's been in existence, for 2 months, 3 months. We've had it for, weeks. So we're learning at the same time, putting information out. So I think if there was some better messaging that went out around that, that would have really been very helpful. But it's really hard to say what would be one of those key things that I felt like is practical, that we would have known that we could have done. I just don't know what that would be, other than trying to make sure that we had supplies that could have met the most stressful part and the most tangible way in which we could have impacted the response.
So it sounds like the science was trying to catch up with everything that was happening. Yep. It seems like I recently heard that some of the test kits, there may be a question about the expiration date on them, and if they might actually last a little longer than what might be stamped on the box. So that's just an example of something I've heard about in the news. I don't really
actually that happened throughout. We would and we were very careful, even with vaccine. I was told, don't discard vaccine because it's expired. Don't discard test kits because they're expired. Now, sequester them, make it very clear that it's not to be used in expired state. But there were multiple times that we would get beyond an expiration date, and we'd get notification that expiration date had been extended. That happened multiple times for multiple products. So that's why we would sequester it, because it might be good. Or we may get an indication. We would never use it as expired, but we wanted to make sure that we didn't throw it away and then find out, 2 weeks later, oh, they extended the life of that. Great. Because again, resources are so precious on that. So yeah, that was definitely a common issue.
The mental health aspect of dealing with this, was that another area that was evolving as things were happening too?
It was, and I know for me personally, it was obvious that there was going to be a significant mental health impact on this moving forward, but I don't think I appreciated just how impactful that was. Um, I think for me early on, one of the things that when I really started to recognize scope of mental health impact and the potential long-term effects, when we really were having the discussions with the schools and we started to see the conflict among parents, school boards on how to approach this. What's the impact of shutting down? That's where it became obvious to me. Okay, this is when I first started hearing about seniors that are missing their senior year, engaging, and then I started thinking about third and fourth graders that are making social connections and developing socialization skills, and then all of a sudden they're in front of a computer trying to do school. So really recognizing, okay, this has changed the entire dynamic of their development. And then on the other side of the spectrum, what was really, incredibly painful at that point in time is getting the phone calls from children of parents that are in long-term care centers and calling up saying, mom's not dying of COVID, she's dying of loneliness. And she has no, personal interaction. We can only see her through a window. Those are ones that are, you really start to recognize, okay, and that's an impact, that's an effect right now. And how do you answer that? Because they're right. No question that was an issue. There's also no question that when you open it up, more people are at risk of getting COVID and dying. It's, again, that COVID conundrum. What is a good answer for this? Because absolutely understand the worst case scenario and those potential outcomes, and struggle with that, wanting to meet that need, that true heartfelt need, and try to balance that with the knowledge of the science that yes, but if we don't take some steps, more people are going to be in a situation that they die. And the impact on the elderly early on was just, that's where the impact really was so heavy. So the mental health needs of this were just devastating, to be honest with you. And I think, from a public health perspective, we look long term. We always think in terms of what do we do today? What is that going to impact the health of the state 5 years down the road? Because we don't, in public health, you don't really see immediate returns on your investment. You play a long game. And
you don't want to be reactive.
Yeah, exactly.
Right.
You're trying to prevent. That's what we focus on is prevention. So I really have concerns of what we're going to see even 5 years down the road when we look back at the numbers, because that's when we'll really kind of understand a lot of this impact and what has this done to this generation. And hopefully, I feel like we're a very resilient state. We have experienced a lot of tragedy and trauma, mostly natural disasters, and we've endured a terrorist attack. We're a resilient state. We have our Oklahoma standard and everything, and hopefully that helps mitigate a lot of these challenges. But I do worry about what this impact could be.
What were some strategies that you developed or had for yourself to deal with the stress?
Well, the challenge was finding time. So, family, my kids are grown out of the house, but, my wife at home, she was wonderful she gave me the space. She recognized the scope of what was going on. So, she was extremely supportive. When I could get any time, I tried to do a little woodworking stuff, kind of one of my hobbies, trying to do something to just not think about this, to decompress a little bit. And so anytime I could find something like that to take my mind off what was happening and be, especially if I could be active doing it, that was pretty valuable to helping cope. But that time was just really limited, especially early on, very limited. I think the team we had, the coworkers, people we could kind of talk to, talk through things with, that was very helpful as well. There was a lot of debriefing sessions, and especially early on, I know we would have with our regional directors, and that they're the ones I was responsible for. We ended up setting up 7:30 calls every morning, and we'd have kind of a debriefing call, and for everybody to be able to kind of talk and just express their frustrations, because each one of them covering the state, they would have different kind of challenges, but at the same time they'd be very, very similar challenges. And to be able to talk through that and understand, okay, it's not just them. Then we do the same thing at the leadership level at the state, and then with the partnerships. I know many times, working over at the MAC, the Multi-Agency Coordination Center, kind of talking through it with others, with the National Guard, and just kind of recognizing nobody was in this alone. There's a lot of people in this, and let's just talk through and let's do our best. It doesn't eliminate the stress, but it always helps to deal with it when you know that there's somebody you can talk to about it.
At what point were you able to back off a little bit from the daily calls and communication?
Well, it was months into it. I can't remember exactly how far. It's kind of interesting, the period from when it kicked off until probably at least, I would say, 6 months into the vaccine rollout is kind of a blur. It really is. And when I look back at that time, we laugh about that, kind of refer to it as COVID time. It's everything gets jumbled up in there, but it was several months that everything was daily. And even when we switched from daily, we went from, we titrated to 2 or 3 times a week, and then maybe weekly. And then there's still a lot of things that we initiated at that time still go on weekly, because it did enhance our appreciation for internal communications. So a lot of good habits came out of that. But no, it was several months. I can't even remember when we started to titrate down on some of those, but
Is it tied with the vaccine?
In a way, it was tied with the vaccine. So early on, we looked at surges. We looked at what was happening, and it really was tied to those waves. And so when we saw the initial wave go up, everything up through that initial wave to the back end of that wave was pretty much daily, all the way through that. And then when we got into a little trough in that wave, then there was kind of some backing off, maybe temporarily, then another wave, and then we ramped back up. When we got to the vaccines, and especially early on leading into the vaccine, because there was a lot of effort. Vaccines rolled out in December of 2020. Yeah, it's December 2020. So that's during that time when my COVID time is got everything jumbled up. But we rolled it out in December, is mid to late December when the first vaccines arrived. But months leading up to that, there was intense effort to prepare, because we knew what a challenge it was going to be to roll out the vaccine, the logistical challenge, trying to figure out who gets allocated these first resources, these very limited resources, who's our most at-risk population. All of that effort was going on. So while we may have had a little bit of a lull even going into some of that, the planning was really heavy. I would say we were probably pretty much on a daily regimen of a lot of these communications and stuff all the way through the rollout of the vaccine. That seems like such a long time. Now, to me, it seems like it was such a long time from March, late February, early March, until the vaccine rollout. I mean, it feels like that was 2 years or 3 years, and to sit here and reflect back, that was like 8 or 9 months. Yeah, that's kind of hard to look back and reflect like that.
It seems like Oklahoma had good strategies for the vaccine rollout. Could you talk a little bit about that? And were we different from other states in the rollout and how it worked here?
Yeah, I'm pretty pleased with the preparation we did and the early rollout efforts of the vaccine. That's where the partnerships were key. So we had, months of planning. We had a team that was focused on getting everything together, and CDC required a plan from us, which we would have done anyway. But we had our team together. We brought in our partners. We wanted to also make sure that we leveraged the state public health system, because we're a little unique in our public health system compared to other states. So we have good county health department presence across the state, which means we have a physical presence in with coverage of almost, we've got 7 counties that don't have a county health department, that are very, very rural, but they're typically surrounded by county health departments on their borders. So we had a good infrastructure working with our partners, Oklahoma City, Tulsa health departments, and then all the other vaccine pandemic providers is what we call, that we signed up ahead of time. And we had a large network of those around the state. So we prepared before even the first vaccine hit the state. We had a large partnership built up to where we felt like we could get it everywhere. And then our plan was, we can't concentrate it all in the urban areas. So we look proportionately how much should go to the metros, how much should go to the rural areas, and let's don't punish somebody because they live in the panhandle. Let's make sure regionally we get a distribution of it. And one of the early goals was we want every single county in the state to have somebody vaccinated within that first week or so. And I think we hit that. I mean, we got it spread out really good. The challenge was definitely what populations to take care of. We knew from the data it was our 65 plus population was at the greatest risk. Those are the ones we really focused on. But our rollout, I think we were able to leverage our system and really do a good job rolling it. And we had fantastic staff out that took lead. We have always done a lot of drive-through flu clinics and large-scale flu clinics. And this is where a lot of the exercises that we had done in preparation really paid off, because we just had to tweak them for this particular one. So that part went really good. Now, what didn't go so well, that was a frustration for us, was there was a system put forth by the CDC where they contracted with different pharmacy chains to where they could go in and they would take care of our nursing home population, a long-term care population. So we had opted in on that, just like I think there's only one state that didn't. I don't think West Virginia did, because they didn't feel like it was the right fit for them. In retrospect, I kind of wish we had done the same thing. But so we had a parallel process where those groups went into long-term care centers and provided that. And they didn't do a bad job of doing it. They just didn't have the resources to do it at the same rate at which we were able to. So we were already moving along and moving to different categories of people before they were even through the first run of our long-term care centers. We ended up even kind of switching over and pulling that back and going out and finishing up some of those. So I wish we had taken on long-term care centers ourselves early on and gone in and done that to get them taken care of a little faster. But overall, I was pleased with it. We were, our goal, this is one thing that we did different, is we did not worry about holding second doses. If you recall, it was a 2-dose series. And we went off the premise of we're going to give everything we can, and kind of the way we would say it is a vaccine in a freezer will save no lives. Okay, so it all needs to go in somebody's arm. So we didn't worry about that. And the plan was, as more vaccine comes in, then we roll those into second doses and provide them. So we made use of every vaccine that went in, and then we tried to get as close to possible as 100% turnover of that vaccine each week, because it came in weekly shipments, and we'd find out what we were going to receive at the beginning of each week. So really good planning, all that. And then also what I feel like we did well is we anticipated when to go to the next group. And it was interesting, because what we found out is our rural areas it was like the canary in the coal mine. They would be our trigger. Some of our more rural areas, especially like Southwest Oklahoma, when they started seeing demand die off in the category, then we knew that we were within a week or so of demand dying off in the urban areas too. Mm. And so we would time it such that we were anticipating we were switching to those new groups before we created a lull. Because if you're focusing on, this is the group that's eligible, if you wait till you try to get everybody done in that, then you're going to be sitting on vaccine, because you're going to have different demands around the state. So we anticipated, and then we overlapped the groups that way. And just because we started a new group didn't mean that we weren't still vaccinating the previous group. That all went well. And early on, the first 2 or 3 months, we were like in the top 5, top 6 of the country on getting the vaccine actually into people's. Then we hit a wall. Then we hit, I think it was April, early May, when we really hit the wall. And that was when we just hit that demand. Demand stopped for a lot of them. And that's where the resistance. So, I feel like we did a good job of taking care of those that really wanted to get vaccinated. Mm-hmm. And then all of a sudden we hit kind of that wall, and then other states surpassed us on the vaccine percentage and the rate of the population vaccinated. That was disappointing for me, in that felt like the higher the rate, the better we could slow down the spread, but also recognize that we're in Oklahoma and we respect people's rights, and we didn't want to go into a situation of trying to force people to get vaccinated either. So the focus was, okay, our job was to make sure that people wanted to get vaccinated had the opportunity to get vaccinated. And I feel like we accomplished that pretty well.
In what ways did your armed services experience influence your work with all of this?
So in the Air National Guard, I spent many years as a flight nurse. We did air medical evacuation. Then I went to a medical group as a medical group commander at the time this occurred. So I'd worked with kind of all aspects of medical in the Air National Guard. So I recognized the resources and the talent we had in the Guard. And I think that was recognized by the governor and others early on, because the National Guard, General Mancino, he was kind of heading up the MAC and organizing that and everything. So the talent of the Guard was recognized really, really early. For me, what I was able to see by having one foot in each world, I was able to see what they could bring to our efforts as an agency, especially when we started rolling into some larger scale operations. Because one of the challenges you have for a public health agency trying to respond to a large event like this is resources. Because you don't staff for large events, you staff for the day-to-day. And then you have to have surge plans. And we have Medical Reserve Corps, which was fantastic for us, especially the vaccine clinics and all that. That really helped us bring in volunteers. We worked with some temp agencies to bring in people to help us out. But those resources aren't necessarily, they don't necessarily bring instant capacity to the fight, if you will. The Guard brought instant capacity to the fight. If we said, I need a dozen people in each one of these districts around the state, then I knew the Guard would provide a dozen people in there, and they would be accountable. They would be there, and they'd be prepared to take instruction and execute. Mm-hmm. And that's what they really brought to the fight for us, and being able to get nurses in to help us and get our vaccine clinics. And to go out and for the health department, you could go across the state and you could look at these, especially the vaccine clinics, and they help before the vaccine clinics, but really the vaccination rollout. You'd see uniformed personnel side by side with our staff in scrubs, and they just worked so well together, hand in glove. And that was reassuring. I even had some people that was under my command at the medical group at Will Rogers that I kind of activated in that role, or approved for them to go and do this, and then I would see them out in the field working with our agency right alongside health department staff. Mm-hmm. And that was, it was really great to see that. But it gave us instant capacity, not just on nurses, but logistical support, because there's a lot of logistics to go to those large scale clinics. They just provided all that. And then they could be mobilized to go to Western Oklahoma, and they would stay up there, and they were there to support in areas that we had trouble finding a lot of resources. So the experience with the Guard, for me, I felt like it was very helpful, because I recognized what they could do to help us. And then Guard leadership in the state was just fantastic on getting them to them, and the service members were fantastic. Now that switched a little bit when we got to the hospital surges that happened. So, keep in mind, we did the vaccine rollout, we kind of hit the wall. Those operations start to scale back into just routine operations. And then Omicron comes up in late 2021. We had already pulled back on our Guard and reserve at that point, because we didn't want to, overuse or abuse that system. And because our clinics had scaled back, we didn't have the need for them like we did. So we had a lot of discussions, with our hospital partners, with the Guard, and with others about, why don't you mobilize the Guard? We need nurses. We need some help in the hospitals. Absolutely true. They need help. And we were kind of desperate trying to figure out how to help them. In that respect, I felt like, part of my input on that was, but we can't look to the Guard to help there, because these are citizen soldiers and airmen. It doesn't help the hospital systems if I forcibly pluck a nurse out of an Integra system and put them in uniform and then drop them into an OU system. Okay, I just disrupted operations over here and then threw somebody new in the mix over there, but I didn't really increase the overall capacity of the state. So we resisted activating the Guard when we had the surge for the hospital and such, and those resources, because primarily your Guard is state resources that are already embedded in those healthcare systems. During the vaccine rollout, when we weren't having the surges in the hospital, it was a plus. It was a plus up on capacity. There, it wouldn't have helped. It probably would have been a disruption, because we would have had systems that all of a sudden would have been without their regular staff, if that makes sense.
Mm-hmm. It does. So in, I think I read February of 2021, you testified before the House Science Committee on the hearing over COVID-19. Mm-hmm. Could you tell me a little bit about that experience?
Sure. That was a invitation to testify. It was really what they'd asked me to bring to the table was experiences on rolling out vaccine in rural parts of Oklahoma. So talking about the challenges that a rural state would have on getting vaccine out, and what the support systems and everything looked like on that. It was a good experience, of course, with everything with COVID at the time. That was a virtual experience. It went on for, I do remember pretty specifically, we were there, I think there were 4 of us maybe that testified. And so we were, a panel on screen the entire time, and it was 4 hours long. So I do remember being quite thirsty and pretty desperate need of a bathroom break during that. So it was an unusual experience, even though it was virtual. didn't have the option to turn the camera off. But no, an honor, obviously, to testify Congress about that, but to be able to provide input on what our experience was and what the challenges were, that was really something I appreciated. It was, and I think it was Representative Lucas that had reached out or at least put in the request based off of what it's seen on our experiences on rolling out the vaccine. So to be able to share what our challenges were and what our successes were, I was pleased to be able to do that.
Did they provide you with questions ahead of time?
No, they did not provide with questions. So provided a statement, and then they just asked questions on the spot, and they went to each member. So each member provided their own questions or asked their questions as they went through. So I don't recall any advance notice on what those questions were going to be. It's kind of on the spot. And fortunately, there were, like I said, I think there were 4 of us on the panel, so they got spread out among the group.
Mm-hmm. Has there been anything that that has influenced that in any way as far as the visibility, or were you contacted for follow-up with anyone that was there or anything like that?
I mean, we had follow-up questions that came up from committee members, but no additional follow-up on that. We most of the follow-up and the questions I would get was probably more based off of the media updates that we were doing, especially during the vaccine rollout, because at one point we were doing, I can't remember if it was 2 or 3 times a week, but we were doing very frequent updates on the vaccine. That's where most of the follow-up questions and contacts and everything came from.
Okay, one of the things that you mentioned in the testimony, the part of it that I saw online, was a 2-in-1 system for those without good technology options, and I wasn't quite sure what that meant.
So yeah, what we did is we partnered with 211, which is the statewide. You call 211, you can kind of get linked to resources. So part of the challenge that we had, and something that definitely we had conversations about in that hearing, was trying to have a system, some kind of technology system that would allow us to roll out the vaccine to a large segment of the population in a short amount of time, while also maintaining accountability and meeting federal requirements for getting the vaccine. So part of the federal requirements were that we had to enter all the information into a system that it could be tracked, and we knew who had been vaccinated, who had gotten 1 dose versus 2 doses, and all that. Not unusual. There's immunization registries that are out there, but our registry wasn't really equipped to pick this particular one up in real time in a expeditious way. In other words, we need to move people through quickly. And I couldn't have somebody come and sit at a desk and then somebody type out all this information into the system and then enter their information and they go. Completely inefficient, and you're going to drag out your operations. So we contracted with a company to come in and help create a system for us. We had the option to use a system that the CDC was using as well, but the reports we got on it that it was maybe not as well developed as our own. So we got a system put together. It was rough for the first couple of weeks, especially navigating. We had some challenges. I'm not going to lie to you. New IT system, that broad, that big, rolling out that early, had some challenges. We worked through those and really found some advantages to it. But the real problem we had early on was that we had a new technology system, and our population focus early on was 65 and over. And so there's a lot of struggling with that population with this new IT system, and understandably so. I mean, it was difficult for some people that were fairly savvy on IT systems, but trying to bring those together. So what we did is we worked with 211, and we set up a phone bank essentially to where those individuals, if they struggled with that, and we encourage family members to help them get signed up and all, but if they struggled with it, they could call 211, and then we had a group that had partnered with them. The call would get sent to them, and they would help get them entered into the system to make appointments and such for them. So again, getting back to the partnerships, recognizing we didn't have the resources to do this all on our own. 211 is an existing system in the state that's recognized as a source of referral and information. So we want to capitalize on that and not create a new phone number, a new thing for somebody to learn. So that ended up being a good partnership, not without its challenges. And it was difficult for a lot of our elderly that were working through that. Not just the elderly. There were others that struggled with it. We were pushing people, be a neighbor, help them out, help people out that are struggling through this. And a lot of people stepped up and really did that. But we needed some kind of system just to manage the volume early on. So we didn't have the option to do it manually. We wouldn't have even gotten our vaccine if we'd had a manual system. So yeah, definitely a challenge, but that was kind of how we tried to overcome that in the short term, was through those partnerships and existing systems.
This just raised a question with me thinking about that. So the shipments that were coming in, was one of the factors related to how much vaccine was coming in, how much had been used? Was that an advantage to
Absolutely.
getting more people? So that did
Absolutely
impact
was. Utilization rate. So, well, let me qualify that.
Okay.
And first of all, know that there were certain storage requirements for vaccine. That was a real problem. This required ultra cold storage, which we had never done before. That was part of the planning. That part went actually pretty smooth. But it limited where the vaccine could go, so it created distribution and logistical issues. Early on, they did allocations based off of your population. That's how the early allocations went. We were running through ours very rapidly, and we were using it up as fast as it was coming in. Other states were sitting on vaccine, and it created a frustration. So early conversations were that factor in utilization rate too, because otherwise, again, the same theories that we used is you're not doing the population any good if you have vaccine sitting in a freezer. And then there were indications that they were going to do that. There was a little bit of that from what we could tell, but not much. It was mostly based off population allocation until we got further into the rollout. And by then we'd gone through several different phases and gotten through a lot of the population. Then they started focusing more on, we're not going to send vaccine to states that aren't utilizing it. Well, by that time, we were already starting to get to the point that we had vaccine that was starting to stockpile because the demand just died. But early on, we really focused on the theory that we don't have a good argument for more, and we did get more. We did argue, and we would get more here and there, and so we were scrambling for it. And we felt like our best argument for that was we're utilizing it. We're getting it all out. Mm-hmm. So everything you send us is going to get in somebody's arm within the week. Mm-hmm. So that was part of our strategy.
Mm-hmm. Okay. All right. It's just to let you know. So it's about 5 after 11.
Okay.
So,
I'm okay if you're okay.
Okay. I'm good too. Thank you. Did you have any, from a personal effect, do you remember the first time you had to start wearing the PPE and what that felt like?
Yeah. So early on, it was interesting, and I was at the MAC, our Multi-Agency Coordination Center, when we first started wearing masks. But it was interesting because in the early days, and again, this is one of the challenges of the pandemic and the new science and not understanding. If you recall, early days, there was even discussion from the federal level that masks may make it worse. With the theory being people are going to be touching their face, they'll be constantly situating the mask, and therefore they're putting their hands, in an area where they may, get the virus on them, and then they'll spread it. There's a lot of conversation around the masks are probably not going to be effective. And then it switched. And then we went back and said, okay, we're saying masks were effective, which I think that hurt the credibility, early on. But that was part of the early challenges. So yeah, I remember when people first started wearing masks there, and that it's just cloth mask at that time because we still had limited PPE. So everybody was making them, and we had people across the state making them. So yeah, it was a bit of surreal. It was a bit surreal to see that. And then as that kind of ramped up and see more and more of it, and then when it reached the point that it became a politically divisive, or just maybe I shouldn't say socially divisive type of issue, then it really got into a interesting, we'll just call it an interesting realm of trying to watch that play out. Anyway, personally, I didn't have any issue with wearing a mask, and certainly appreciated those around me that did. But I also respected those that didn't. But early on, I think everybody was pretty adopting of it. Early on, everybody was pretty adopting and accepting of the shutdown, the temporary shutdown. Mm-hmm. But that was a pretty small period of grace there, and then the tolerance left pretty quick.
Yeah. I don't think we've really talked about this much yet, but the VA centers and or maybe when you were talking about certain populations, would the VA centers be included in that?
Yeah, the VA centers, there's 7 VA centers across the state operated by the Oklahoma Department of Veterans Affairs, and they're long-term care. They're in the long-term care categories with us. They were also part of this program, this federal program, to where they were going to be taken care of by a federal partnership, a federal contract. Mm-hmm. And on that federal contract, vaccine went straight to, it came out of our allocation for the state. That's one reason I was very frustrated with it, because it was part of our allocation and it went to our partners, these federal partners, but they weren't utilizing it as fast as it was coming in. So to me, that was vaccine sitting there not being used. It appeared as if the VA centers were some of the last ones to get served in that planning and that execution for vaccinating them. So I know the director of the VA had reached out to me. I'd had multiple inquiries from others about this. I talked to the federal partners on it, and they had plans to get to it, but their schedule, they couldn't do everything at once. Mm-hmm. So their scheduling was pushed out. So we finally just said, we've got to take care of these VA centers. So what we did is we got with the federal partners that received the vaccine and said, we're going to take that vaccine. And they worked with us, and okay, we're going to let you do this. We let the feds know what we're going to do. We took the vaccine and we put it in the hands of our local health departments, the ones that were used to taking care of it, had taken care of a lot. They actually had taken care of a lot of the long-term care centers, because each long-term care center had the option to opt into the federal program or not. If they didn't opt into it, then we took care of them. And that was kind of one of the big distinctions. The ones that we had taken care of, we took care of like in the first week. Mm-hmm. And we canvassed and we're like recognizing the challenge. So we took care of them almost immediately. And then we had the VA centers there like for the last. So we worked with the partners. We took the vaccine. We put it in the hands of our local staff, and they went out there and they got their vaccines like in 3 days or something. It was like that weekend. They just went out and did it. Mm-hmm. And we're proud to do so. And that was gets back to the heart of the staff that were working the front lines. They knew that they were saving lives in doing this. They knew what that vaccine meant to especially a very vulnerable population like that. And they were eager to get out there and take care of them. And that's really, I would say, probably the number one reason we were successful on our vaccine program, as successful as we were rolling out, is because our frontline staff and our volunteers and our military partners and everybody who was involved in that process knew how important it was to get that vaccine into the arms of those that were really vulnerable. and they stepped up to the challenge. So we were pleased we were able to take care of our VA partners. That was a good partnership. We were pleased to do that. Just hated that it took as long as it did.
Were you surprised when the variants started emerging?
Not really, unfortunately. I mean, it's the nature of a virus to do that, and we know that in public health, and we know that from our experience looking at flu each year. You just get different types that come out. So not necessarily surprised. Disappointed in a way, but also not in another way. And what I mean by that is the evolution of the virus, I think, is really probably is what has helped get us to this endemic state right now, because it's evolved, but it's evolved in a less virulent form, in a less dangerous form. Mm-hmm. So it's something that is something that we can live with without it devastating our healthcare system and all. So I think it was inevitable that was going to happen. I mean, it would have been great if the virus had just kind of died off and gone away, but that wasn't going to happen. So, I'm not really surprised that this happened. I can probably go to about 11:15.
Okay. We're about 2 minutes out
okay.
for that. Is there anything that I haven't asked you that you would like to share?
Oh my. I just think there's so many lessons to learn from this. For us, it's we look at it on what we've learned on the practical how to respond to a pandemic, a health crisis, how to bring partners together. There's that lesson that is just very stark, and those are the easy ones to capture in the hot washes and the after action reports and all that. There's also the social lessons to learn from this. I mean, this has really been an example to me, and I often talk about in public health. Public health is science-based, but there's an art to public health as well. Public health very much intersects in the policy world and others. And this was an example of how you can follow specifically the science and the science recommendations, but they do no good if the population is not willing to follow those recommendations. So how do you find, that ground to where you can provide those that are willing and interested, provide them the resources and tools they need to protect themselves, and make sure that everybody has the information they need to protect themselves, but at the same time kind of respecting those individual opinions. We knew certain things would be the right thing. If everybody did them, that would be the right thing to stop the pandemic, or not stop it. I don't think anything would have stopped it, but to slow it. But we also recognized and respected that if you push too much on some of those things that are just not going to be accepted, you experience a backlash and you go backwards. So there's just been a lot of lessons that I think we're still trying to kind of dissect and learn from this experience on the social side. I think it'll take some time to look back and really understand what actions public health took, what were the reactions to that, what were the consequences, and was it positive? Or was, maybe some of the more moderate approaches may be more effective in the long run on getting people on board? Because we saw the more things were pushed in the way of mandates and things like that, strong pushback and backlash. What does that do to the people that are kind of in the middle, that are trying to decide how they're going to respond? And I think those are things that we also need to look at as we move forward and really understand. How was our response to this? What was the impact of it? And did we get the responses that we needed? Were we effective in the decisions we were made, or were we just obstinate in it's got to be this or it's got to be that, not recognizing the art of what we were trying to do. It's really kind of fascinating, the complexities of the whole pandemic and the whole social interaction and, political interaction, all of that stuff. I think there's probably years and years of study that could take place looking back at that and dissecting that and creating some lessons learned.
Okay. Well, I thank you very much for your time today. I've learned a lot from your work with this, and appreciate your leadership very much.
Thank you.
And your military service as well.
Thank you. Appreciate it.
Thank you.